Good morning, everyone. Just waiting for the last few people to get through the waiting room, and I'm sure others will join us. So, good morning. My name's Louise Halfpenny, and I'm the Director of Communications. I can see many familiar faces, but I know also we've had some new members to the Stakeholder Reference Group. So you're very welcome. And we're using Zoom, obviously, so thank you for downloading that if it's your first time, and here are some notes on how we're going to run the session. So microphones will be muted. In our public meetings, we've asked people to keep their cameras off. I don't mind if this is a smaller group, if you want to keep your camera on. If we run into problems with bandwidth, we may ask you to turn it off. Two ways to use a question. I'll ask a question, sorry. So you can use the chat function, or you can ask a question in person by using the raise a hand function. And I'll also be scanning just to see if people are physically raising hands, if for any reason you can't get that raise hand function to work. We will try to get through all of your questions. We can't always, and I do ask if you send them on chat that you keep them as short as possible, related to the presentation, and it's unlikely we'll answer hypothetical questions, because that's really not what we're here for today. We're here to talk to you about our proposals and to answer questions on them. So the aims of this session are to explain what Your Care, Your Views is all about, to talk to you about our engagement programme, and to ask for your help in reaching out to the communities that we serve. We'll also tell you a little bit about the survey, and hopefully at the end there'll be opportunity for you to ask questions. So Your Care, Your Views has been a long time in the making, and the title, some of you will know, Your Care, Your Future, and we've chosen the title really to show the link back to some of the principles of Your Care, Your Future. And Your Care, Your Views is built on a range of national documents, so really looking at national strategy, but also local and regional strategy. And you can find out more about all of these documents if you go onto our website. So I'm now going to hand over to Esther, who will introduce herself and take you through the next slides. Thank you.
Thank you, Louise. My name is Esther Moores, and I'm working very closely with our clinical teams to plan out new services and premises. So we're very much challenging ourselves as we go to say, how can we do things differently? Where do we think there are opportunities to improve? And so my role is very much working with the frontline staff to capture that and to look at how we could make it happen. So I think our starting point is to say that what we're aiming for is to make sure that each of our 3 hospitals has a very clear purpose, so that we can make sure that they do what they do as well as they possibly can. So Watford would continue as our emergency specialist and complex care site. St Albans would really focus, as it does now, on planned surgical care, and also being a real place for ensuring that we can get quick diagnosis for patients with suspected cancer. And then Hemel, the intention there is that we will really improve our services around planned medical care and aim to work very much as a team in caring for patients that have long-term conditions. And as you can see from the final bullet point, the intention is that we will have urgent care services, outpatients at all 3 of our sites. So on to the next slide. A lot of what we do can be informed by history and how services have worked previously, and that's really important. We want to keep the really very many good things that our clinicians provide already, and the things that we know that patients already appreciate, but we do want to build on that, and we are aware that, as with most things, the opportunity to really specialise is a real driver of excellence. So that's why we're really looking at how we can group services together really, really sensibly, rather than just recreating things as they already are, so that we can provide the best care possible. And the buildings themselves enable us to have opportunities to change our care, of course, so we can make sure we've got the right diagnostic facilities to support the clinical services on each site. We are aiming to have a much higher proportion of single rooms available for patients, and to make sure that we really make the best use of this opportunity. Underpinning it all, and we will come back to this later, is how we can use technology, because as we've seen with COVID, we can make real changes and get care into patients' own homes in a different way, thanks to all the opportunities of virtual technology. And that's very much a changing model for outpatient care. So just to talk a little bit more about each of our hospital sites, I will start with Watford and then hand over to Freddie Banks to talk more about the other sites. You can see the list of services that we have on the Watford site, and the real opportunity here is to look at how services can be co-located so that we get the right mix of services together. So, for example, our emergency department and our assessment services for patients when they are first in our hospital at Watford, they're not in the same place at the moment. And that's because the assessment services have grown over the years, and we don't have the space right by our emergency department to put them all together. But our clinicians tell us that actually what you would really want is for those services to be co-located with diagnostics right in the centre, so that we can really look at patients across our teams to make sure that we can reach, we can confirm the right pathway of care for that patient as soon as possible. So making sure that, you know, we've got our women's and children's services very accessible to the services that are in our main building. At the moment, they're in separate buildings. This is a really good opportunity to bring those things closer together. And as you can see by the next slide, our staff are really engaged in planning and thinking about how services could work differently in the future. And this quotation from Vicky, intensive care matron, just highlights what a difference it will make for our staff to have better facilities. And of course, you know, we know it will make a massive difference to the patients that we care for. So over to Freddie to talk a little bit more about our other sites as well.
Hello, my name is Freddie Banks. I'm a consultant urologist here at West Herts, and I'm also the Associate Medical Director for Clinical Strategy. I think over the years at West Herts, we have effectively fitted specialties into the services that were provided or were available on all three sites at Hemel, Watford and St Albans. And the problem with that is it has meant that we have ended up with very, very fragmented services. So there's been a little bit of everything everywhere. And I think we have really woken up to the fact that that is not an appropriate way to treat patients. That for a patient to come in and have an outpatient appointment at Watford and then have a scan at, for the sake of argument, say Hempstead, and then have a biopsy at St Albans, and then come back to Watford for the results. This is a very, very fragmented service. And I don't think that is an appropriate way to treat patients in the modern era. And what we have now is hugely improved imaging technology, which can really speed up the diagnosis. And we are, as clinicians, much, much more reliant on this technology for the diagnosis. So we're seeing much less importance put on initial examinations and a much greater emphasis put on investigations. And I think we are duty bound as clinicians to really speed up that process for patients And I think there is a seismic shift in the way that we treat patients, in that your first outpatient appointment shouldn't really be seen as the first outpatient appointment, but actually the culmination of your investigations and hopefully arriving at a diagnosis. What we would like to do then is to effectively clump all of the specialties that are reliant, particularly on imaging, together, particularly for those that are looking for cancer diagnoses, together, so that we effectively have a super diagnostic centre. And our plan is to base that at St Albans Hospital for the surgical specialties. So that if you're coming in, for the sake of argument, as a urology patient investigating potentially for prostate cancer, we would manage to have all of the investigations done under one roof, ideally all on the same day. It'll end up being a different patient experience, that you'll probably spend rather longer at hospital having these investigations. But I think you will have a much quicker and a better experience, because you'll get everything done ideally in the same day. And if we can get to the point where I would like to end up, you'll actually get your diagnosis on the same day as well. And then it's really just a question of either discharging you if we haven't found cancer, or if you're unlucky enough to be found to have cancer, we can then plan what treatment that is going to be and where that will be thereafter. Ideally, you can actually leave hospital with that in your diary, knowing exactly when and where the next stage of your treatment will be. So I think we have an opportunity here to really define specialties and the way that they work, and to get the hospital estate to work for us rather than against us in terms of delivering these services. The other huge advantage of putting the diagnostics together is you put all the clinicians together, and then that allows us to create an elective surgical site, because we've got colleagues and clinicians available to assist in theatre should you need it. And that means that we can improve the range of operations that we do at St Albans, so that it's not just effectively a day case hospital with a bit more, but really a rapid turnaround and efficient building to really deliver elective surgical care. And I think that is so important, because in my view, as a clinician, if we say we're going to do an operation on a certain day, you should get that operation on that day. And that should be the standard that a patient expects and a doctor expects to deliver to. And in order to do that, we need to have an elective surgical site that isn't contaminated by patients coming in overnight with emergencies, which is the traditional model across the NHS, that elective surgical services give way in order to facilitate surgeries in emergency patients. And the key advantage of having a separate building with that is you prevent that contamination from emergency surgical services. So elective surgery is delivered on time without cancellation. So I think the combination of having a specialist diagnostic and cancer centre in conjunction with an elective surgical services site is a very, very attractive model. And that is the way that we are planning to go with it. And that's really a quote from myself, just explaining how important it is to try and consolidate all the surgical services and the key components of a diagnostic pathway together, and try and get them all in the same place. And a further adjunct to this is I'm certainly challenging my colleagues and clinicians as to why do we need to see a patient on a face-to-face appointment more than once. I think it is probably important in a pathway, but a lot of the diagnosis, a lot of the results and subsequent follow-up, we should be able to do either over the phone in the simplest way, or on platforms such as Zoom, which we're using now. And I think patients are getting very used to this. We've done a lot of this with COVID, and I think the feedback is actually very good, that it's a much more convenient way of managing patients and should be expanded rather than reduced. Next slide, please. Hemel Hempstead Hospital, in a similar way to St Albans, offers a great opportunity to really consolidate services. Our plan for Hemel Hempstead Hospital is, rather than surgical services, this would be the consolidation of medical services, particularly those that have long-term patients. These are patients such as diabetes or rheumatology, some potentially neurology, dermatology. These are patients who often will be having lifelong illnesses that need managing, and they also need a much closer integration with primary care. There's a lot that the GPs can probably manage with a bit of support from consultants, but similarly it needs to be a two-way option, that when the GPs are struggling to control the disease, then they need rapid access to secondary care physicians. So the plan for the Hemel Hempstead Hospital is to consolidate these medical specialties into Hemel Hempstead. And it also, the other key component of these from a patient point of view is that they often have multiple diseases. So it's common for patients with diabetes to have some skin conditions, rheumatological issues. And the idea is that we can actually have multidisciplinary teams able to talk and see patients so that they're working side by side. Again, there is an emphasis on trying to provide one-stop clinics. The imaging component will also be upgraded at Hemel Hempstead to facilitate this advanced medical model. And we really do feel that this is a better way of managing patients. And it really breaks down the barriers between primary and secondary care so that you've got an integrated system. Next slide, please. This is Sandeep Ballara, who's a consultant rheumatologist. And obviously his specialty is one that I think would hugely benefit from this type of model. Again, I think it's an advantage actually being away from the acute hospital, that we can try and get away from managing these patients proactively rather than reactively, which is what inevitably happens in an emergency hospital. Thank you. Next slide.
Good morning, everyone. My name is Helen Brown. I'm just going to pick up now. So I know Freddie's already talked about using virtual appointments for outpatients and how we believe that for some patients that can be a really good option. Our plans for our future service model and for our hospitals is to really make the best possible use of digital technology to improve the way we deliver care and the experience for patients. So as well as virtual outpatient appointments, we're beginning to use apps and health monitoring equipment at home to help patients manage their own condition and to help our clinical teams keep an eye on their conditions and support them to stay safe and well at home. We're currently implementing an electronic patient record, which will bring a huge amount of benefits to how we're able to look after and care for patients in our hospitals, but also working jointly with other organisations. And when we think about our new hospital facilities themselves, there are lots and lots of opportunities to do things differently using digital technology. So things like digital wayfinding, which will help patients navigate the hospitals, or simple things for us like tracking equipment through the hospital, and even tracking patients through the hospital so it's easier for us to find. So lots and lots of opportunities around digital, and we're working really hard to start to use digital better right now, but really thinking also about the future and what opportunities there are with new facilities. Next slide, please. And then again, I know that Freddie's talked about diagnostics, but diagnostics are so important for hospital-based care, and we want to really speed up access to diagnostics and getting good, quick diagnoses for patients by investing in improved diagnostic equipment across all three of our hospitals. So at St Albans, we will be developing a rapid diagnostic centre as part of supporting particularly our cancer pathways. And will be offering MRI and CT at St Albans, which historically we have not done. but we've been fortunate as part of the NHS response to COVID to get some temporary MRI and CT facilities at St Albans, and the plan is to make those permanent alongside a number of other diagnostics. At Watford, obviously emergency care sites, really important that we have the full range of diagnostic services operating pretty much 365 days a year and long working days, so that patients, whatever time they come to the hospital, can get access to really good diagnostic facilities, and organise that better with the rebuild, so that diagnostics is right in the heart of the hospital. And again, for Hemel, Hempstead, diagnostics is going to be a really important part of our medical care and long-term condition model, and will provide plain X-ray, MRI, CT, ultrasound and DEXA scanning, which is a bone density test. So yeah, really focused on diagnostics and expecting to increase our diagnostic capacity on all 3 sites. Thank you.
Thank you, Helen. So just looking at the engagement timeline, so we have started our public engagement, and some of you also joined our public meeting earlier this week. We're also doing meetings in the community, so going out to community groups, and thank you if you've sent us an invite, and if you haven't, please do. We're very happy to come and meet virtually with you where you are, to take agenda slots if you've got any to spare, and to talk to people about our services. We are also going to have quite an exciting range of events starting from Monday of next week, which are really focused on our services. So if you have a particular interest in planned medical care or surgery or any other aspect of our services, there's going to be sessions with some of our senior clinicians, some of our nursing staff, and some of our service managers. So a chance to delve a little bit deeper into particular topics, and we will be putting those dates out later on today. So you will see there's a whole range of different sessions that you can get involved with. We are also running a survey at the moment, and that will close at the end of the first period of engagement. We have commissioned somebody externally, an external company, to run the survey for us, and they will also analyse the feedback, and that will be some of the information that the boards will consider in the summer when they make a decision around our preferred option. And it is part of all the wide range of information. So it is really important that we hear from people across the whole area that we serve. So there will be a QR link on the following slide, I think. So you can share the code with people you know to ask them to carry out the survey. There it is. So you can just, if you've got a mobile phone, you can hover over that and you can fill in the survey online. It does have all the mandatory questions you would expect at the end. I know from feedback that people find this a bit tiresome when they've already done all their thinking about our services, but it's really important for us to make sure that the responses that we get are representative of the community that we serve. So I have had a few questions coming in already, so I will address the first of those, which is one that we get asked quite often about technology and what will we do for people who don't have ready access to technology. It's not going to be compulsory, so we will make sure that we can manage people's care in more traditional ways. So if they need to, or they prefer to, or have a reason why they must come in person, or would prefer a phone conversation rather than downloading an app or doing an online platform like we're using today, then those options will still be available. As part of our move towards the electronic patient record, we will improve how we record people's communication needs, and that will really help us tailor our communications. So we will still be available for people who wish to communicate with us in more traditional ways. I should just say that the virtual hospital for COVID patients has been incredibly successful, and we have cared for over 4,000 people now using online technology. So we are seeing a huge appetite in our patients to have their treatment online, and we think there will be quite a lot of enthusiasm, and that's one of the things that will help us remove around 200,000 outpatient appointments each year, as well as some of the things Freddie was saying about making our appointments more efficient. So that was a bit of a long answer, but technology it's not compulsory. We will still be here for you in other ways. So Helen, I want to come to you, please, if I can, with a question about urgent care services. And I've had two questions. And one is if you could just explain what's happening at St Albans at the moment, and also about urgent care, how we think it will run in terms of will it go back to being 24/7 at any of our 3 sites. So if I can ask you to pick that up, please. Thank you.
Thank you, Louise. So starting with the 24/7 question, the answer to that is that we will only be providing 24/7 emergency care on the Watford site. The UTC at Watford doesn't operate 24 hours, but operates through the core hours of the day. I think from memory it's 18 hours a day. And likewise at Hemel, there just isn't enough demand in the very small hours of the night to maintain a safe and effective service. And it's much better if people are unwell at that time of night that they call 111, and if directed that they then come into the emergency care site where we've got all the staff and facilities to assess them. And the plan at Hemel, broadly speaking, is to maintain the urgent treatment centre as is. I mean, obviously we're continuously improving services and developing in line with the national specification for urgent treatment. St Albans is a bit more complicated in terms of the picture. So historically, we've had a minor injuries unit at St Albans. It's opened 12 hours a day, and it's just been, as described, for people with minor injury but not minor ailment. Then now it's clear and set out at a national level that minor injury services are no longer going to be offered by the NHS, that services like that need to manage minor ailment as well as minor injury. So we are working with the CCG, and this is being led by the CCG, doing a piece of work to say what's the future urgent care service for St Albans and Harpenden going to look like. Active discussion with the GPs in that area about urgent on-the-day care. We do expect that there will be provision and it will be an urgent care service. It probably will operate 12 hours a day, but this is work that's going to be done over the next few weeks and months, and the CCG will be engaging separately on the future model for urgent care at St Albans.
Thank you, Helen. Freddie, I'm wondering if I can come to you with a question about the electronic patient record. So I'm hoping that you might know this, but can you explain, please, how the record is accessible by GPs also? Thank you.
Thank you, Louise. I think we're very much in the design and procurement phase of the electronic patient record at the moment. So I don't have a definitive answer as to exactly how it will integrate with primary care, but having been on a lot of the sort of focus groups and user groups with it, that has been very high in the list of priorities, is that we have an electronic record that does integrate properly with primary care, and also hopefully with patients as well. That I think we're looking at trying to have a patient portal within it so that patients can actually access their own results and correspondence from it, which would be a far more efficient system than having bits of paper sent out. So the plan is that it does fully integrate and also integrate across our other hospital providers such as Mount Vernon and Eastern North Herts, where some of the specialist services are as well.
Thank you very much. Esther, I'm going to come to you with a question in a moment about community ophthalmology, if I may. But before I do that, There is a question about lockdown restrictions making it hard for us to access groups who aren't online. And yes, it is making it difficult, but we are also finding many groups online that we weren't interacting with before. So it's definitely got pluses and minuses, but we have been talking to carers groups and other groups in the community. And although those have been online to start with, they have other groups linked to them. And for those groups, we are doing print runs of our engagement document and our survey. So we do have good old-fashioned paper. So we can, if you let us know of people who would be interested in reading on paper about our proposals and doing our survey on paper, we can make that happen. And so, you know, we are trying to be accessible for all groups, and also local papers have very kindly covered information about your care, your views. So we are trying very hard to get information out there in a number of ways and not just rely solely online. So I wondered, Esther, if I could come to you with a question, and it may be that Helen will chip in here, but the question was about community ophthalmology and how, if we can say a little bit about services that aren't run by the trust, and what do we know of how they will function after the pandemic. I think the concern is that some of these services have disappeared a little bit, and our sites do host services from other providers. So perhaps, Esther, if you could just talk a little bit about that. Thank you.
Yeah, sure. So we have a range of services on our site that are provided by West Herts, and over recent years, in conjunction with commissioners, there have been quite a few services that we have looked to change the pathways to deliver closer to home, both on our sites and in community locations. For ophthalmology, we provide our acute service at Watford and at St Albans at present, and then there has also been a service based at Hemel Hempstead Hospital that hasn't been provided by us. And with COVID, obviously a lot of services have been working quite differently. Now, that doesn't mean that services aren't going to resume. Obviously, we're trying to make sure that we do the right things for patients, and we are managing everything in a safe way as possible. So we are in discussion with services as to when it is appropriate and how they best want to resume. But of course, you know, the most important question is that we do that appropriately, bearing in mind how we want to and we need to manage during COVID. I don't know if there's anything else that you would like to add to that, Helen.
Thank you, thank you. And Helen, if I may, could I come to you with a question about where services for people with leukemia would be cited, and perhaps that gives us an opportunity to describe the different kinds of cancer services that we would expect to see at St Albans and those that are currently provided by Mount Vernon. Thank you.
Okay, I'll do my best. I might ask Freddie to come in if I get any of this wrong, but my best understanding is that our leukemia services are provided on the Watford site in partnership with other organisations, including Mount Vernon, but the Helen Donald unit, we expect to continue to do that. There are some discussions around pathways for chemotherapy and how they might be developed and improved over time, including day case and home-based chemotherapy. And we're having a discussion, actually, we didn't, a few years ago, we stopped doing inpatient chemotherapy in the trust. Actually, this year, we started doing some inpatient chemotherapy. We built up the service at Watford to enable us to do that. Some of the less complex cases, we're hoping over time to further develop that service so more people can have that inpatient chemo done locally. So that's the Watford end. If I go a bit broader in terms of cancer, I mean, cancer pathways are quite complex. There are 13 key tumour types that we diagnose and treat patients for across a whole range of both medical and surgical specialties. We will continue to do those parts of the pathway and to work with other organisations to deliver the total package of care. A lot of that will be focused into St Albans in terms of diagnostics and outpatient care, and quite a lot of cancer surgery also undertaken at St Albans, but there'll also be services at Hemel and Watford. So there's no quick one-size answer for cancer, because it's such a complex issue and it cuts across so many different specialties. But the underpinning kind of aim to get rapid diagnosis and treatment plans in place, and for us to provide care where we're really well placed to do it, but to work with other more specialist organisations as required, kind of remains into the future. Just briefly on the Mount Vernon Cancer Centre, that's a separate process. It's being led by the specialist commissioners. That service is currently provided by East and North Herts, but it's expected that next year University College London Hospital will take responsibility for those services. They are a specialist cancer provider and have got a lot of expertise in that field. I think it's been long acknowledged that the facilities on the current Mount Vernon Cancer Hospital site are not fantastic and not fit for the future, but also there's concerns about cancer services sitting separate from acute hospital services, and that does sometimes create difficulties in providing the best care for patients. So the Mount Vernon Clinical Review has recommended that those services be co-located on the same site as emergency care, and they've identified Watford as potentially the site where that would happen. So we're working with them to make sure that we understand their needs and requirements, and looking at how we would be able to support that in the future. It is a separate programme to our redevelopment, but obviously linked, and we're doing all the work at the moment. I think it would be fair to say that in discussions with our clinicians, they're really keen to see the Mount Vernon Cancer Centre services co-locate onto the Watford site, and believe there are going to be many benefits and opportunities to improve care for patients, both those currently treated by Mount Vernon, but also patients that we currently look after. So that is an exciting opportunity, but it is a separate process, and there will be a full engagement around the final proposals at a point in the future when position on funding has been made a bit clearer as well.
Thank you, Helen. Thank you. So I've had a few sort of travel related questions come in, and one of those is, will there be access to the new hospital, so the new hospital building at Watford, from Vicarage Road? And we don't anticipate there being increased access from Vicarage Road. In fact, we think that the building will, and the site will, completely reorientate towards Thomas Sawyer Way, and that traffic will come in and exit from that route, and that will bring patients and visitors and staff into our new multi-storey car park, and should make getting in and out of the site much easier. And we will, of course, work with local authorities on transport. So we will be setting up a transport and access steering group with input from local authorities to look at public transport. I note I've had a question from somebody who lives in Tring, saying that it can take a long time, over an hour in traffic, to get from Tring to Watford. So we will also be making it clear to people how they can access the hospital by public transport if they are able to. And we do also hope that there will be less reason in many cases to make as many trips, or if you do make a trip to hospital, as we've described, you would get more out of your visit than is currently the case. On the question of trips to hospital, I'm wondering, Freddie, if I could just ask you to explain a one-stop clinic. So I know you did sort of do a canter through, but if you could maybe explain that from a patient point of view, how it might feel and what you might get out of a one-stop clinic, that would be great. Thank you.
Well, what we very much hope with a one-stop clinic, it's probably better if I give a clinical example, actually. So let's choose something like prostate. Prostate cancer is quite a good example, because it's relatively complicated, actually, the number of scans that you need. So there's a question over a blood test, which is typically from a PSA. That is usually done by the GP, so we have that in advance. But the mainstay of treatment is actually or investigation is to have an MRI scan. We would pre-book that so that you would actually attend and go straight into the MRI scanner. We then have to coordinate a radiologist to report that scan. And there is the potential that actually if you've got a very high PSA, we would automatically book a bone scan as well. So you'd literally come out of the MRI scanner, go into the bone scanner, and then we would get the results through from that. We would then have a clinical assessment of you, which often involves simple things as peeing in what's called a flow rate machine and having a quick ultrasound to see how well you're emptying your bladder. So that would be the clinical component in conjunction with examination. And then if we can get it really all tied together, you then actually have a biopsy later on that day. I don't think we could actually get the results of the biopsy back to you in time, because that's got to go off to the lab and be stained and looked under a microscope for, which does take 2 or 3 days. But those would be all of the investigations required for a prostate cancer diagnosis and assessment. And all of those investigations, including seeing a urologist as well, will be done in the same day. So that is very much the model that we would like to do. Another simple example actually would be something, if you have a colonoscopy, that if you're unlucky enough to have a cancer diagnosed with that, you'd actually come out of the colonoscopy, which has confirmed the cancer. You would then need to have a CT scan to assess how far that cancer has spread. And instead of coming back on a different day, you would then actually have that scan on the same day. So that's what's called your staging investigation. So that would then be completed on the same day as your initial diagnosis. And ideally, you then actually go and see a colorectal surgeon, who would be the surgeon to then remove that cancer. So you'd see him, you'd get ideally a diary date for the operation. And if you're not too exhausted, we then actually even plan your pre-op assessment on the same day, so that actually all of the workup for that operation is done. So it would be potentially quite a long day for patients, but it consolidates everything into one sitting and one visit to the hospital, which I think would be a much better situation for patients, and you would leave hospital much more informed and much more aware, which I think would be better for you, so that you're not having that horrible nagging doubt as what does the scan show and what does it show? Has it spread anywhere? Which is what we want to avoid.
Thank you, Freddie. So Helen, I'm going to come to you in a moment with a question about bed numbers and also related to the pandemic. So what we've learned from the pandemic, how that is influencing our thinking about bed numbers, and what sort of work we're doing to make sure we right size the hospital. But before I come to you, I just wanted to pick up a question about a free shuttle bus. It's very unlikely we would have a shuttle bus going between the sites, partly for the reasons that Freddie's just explained. We're trying to minimise the need for people to be zipping between the sites, because we want the sites to have a unique purpose. So if you are having planned surgery, or you're going through a cancer pathway, which may end in surgery, the chances are that all of that would be done at St Albans. If you have a long-term medical condition, then you would be seen at Hemel, Hempstead, and the diagnostics would be there for you. So there shouldn't be the need to be moving between the sites. And that also goes for staff. So we are trying to change the way that services are provided. And in some cases, that means that the service that you need won't always be at your most local hospital, but our aim is to provide the best service that we can, and that isn't always going to be the closest service. There have been some questions about particular services and where they might be. And for those of you who really want to see the detail, we've done a lot of that thinking already, of course. That's really been the work that Esther's been doing with clinical colleagues, and that's set out in our clinical brief document. So if you go onto the website and you look for our clinical brief document, at the back it has lots of tables which show you where services will be provided. So a lot of detail there for those of you who want to do some additional reading. Helen, if I can come to you, please. So it's a bit of a double question here. Firstly, about beds in the event of another pandemic, and secondly, about beds in terms of building hospitals to be the right size. Thank you.
Thank you, Louise. So I'll start with learning from COVID. And obviously this has been a really extraordinary and unusual year in terms of delivering health services. And Esther's done lots and lots of work with clinicians, talking to them about the future requirements of the new hospital and the design. And obviously COVID and learning from COVID is absolutely at the top of most of our clinical team's mind at the moment. So there's been a lot of thinking going into that. And there are some quite obvious things that we will be doing and expect to see as we improve our hospital buildings, and probably some things that are slightly less obvious. So as we move to new facilities, we will have larger spaces, which will make infection prevention and control easier just in itself. We'll be moving to many more single bedrooms with ensuite facilities, which is obviously much easier to manage different manage infection prevention and control again, but also to meet the needs of different patients. One of the biggest challenges in COVID has been trying to separate patients within the hospital, whether they're confirmed COVID, potentially suspected COVID, or definitely don't have COVID, and sometimes a cohort of patients where you're just not quite sure. And that's been quite challenging in our current arrangements, and in the future with more single rooms, that is going to be much, much easier to manage. Probably slightly less obvious things have been conversations about one-way systems. So would we be able to have one-way systems within the hospital if there's another pandemic? More separating waiting rooms again, so that you can manage patients in separate streams. I mean, I can't tell you lots and lots and lots of discussions and thinking around COVID and the future. And it's probably also worth mentioning, as I'm sure people are aware, we're not alone. So there will be 40 hospitals, or possibly even 50 hospitals over the next 10 years getting major investment. And there is now something called the New Hospital Programme that is being run nationally and bringing hospitals together to think through some of these issues, because we don't all need to make our own solutions. We need to come together and work out what some of the design principles are. And our architects, BDP, are also working with some other hospitals in the programme, and there's a sort of peer networking group for all of the architects and design teams supporting new hospital programme to talk together and work out the best way to solve some of these problems. In terms of bed numbers, I mean, actually the issue for us in COVID hasn't been bed numbers in the main, it's been all of those challenges that I've just described. Possibly, obviously, with the exception of critical care, and there has had to be an expansion of critical care facilities through the pandemic, and we've had to care for critical care patients in areas that we wouldn't normally expect to do so. So we are planning for a modest increase in the amount of critical care beds into the new hospital, but we're also looking absolutely at flexibility. So alongside an expanded critical care unit, we're also looking at having high dependency cardiology care and respiratory care. And those facilities, if required, could also be used for critical care in the future. The question about how many beds should we plan for in the future is a really difficult one. And you really need a crystal ball to think about all of the different things that will change in the future that might influence the number of beds that we need. So we have got a fairly sophisticated demand and capacity model that looks at our current capacity, and then it looks at how the population will grow, is expected to grow in future, how clinical needs might change, how clinical care models will change both in hospital and out of hospital settings. Louise mentioned earlier our COVID virtual hospital, and there's a very active discussion at the moment between clinicians in West Hertfordshire to say, look, we think this has worked really well during the pandemic, and there are lots of opportunities to provide more care in that way. So during COVID, that virtual hospital has focused on COVID patients. We're currently looking, expanding that to a whole range of other conditions, respiratory, COPD, looking at heart failure, looking at a whole range of things. And we do expect that increasingly we will be able to provide much more intensive and complex care at home for appropriate patients, and that will reduce the need for hospital beds. Overall, we are planning for an increase in beds, but that is also to allow us to reduce what we call our occupancy level. So at the moment we operate at about 95% bed occupancy. We would like to bring that down to 90 or 85% is what we've currently modelled. We're not quite ready to publish our bed numbers, and one of the reasons for that is we have to go through an assurance process with our commissioners, NHS England and the new hospital programme, so they can look at all of the thinking that we've done and check that again it's comparable with thinking other areas are doing, and that we've got some consistency across the programme. But as I said, there is an expectation that there will be more beds in the future. And then finally, just to say, and I'm sure Freddie pulled some of this out when he talked about St Albans, there will be beds at St Albans for planned surgical care, and that will provide what we hope will be a more protected environment for those patients, both from an infection prevention and control point of view, and also just the overall environment and ethos of care on that site. But also in the event of a pandemic, it is very helpful to have a separate site. And although over this winter, all over the pandemic, we have sometimes had to pause services at St Albans, that's largely been due to staffing shortages. And as much as possible, whenever we can, we've kept those services running and been able to keep them what we call COVID free or COVID protected. So I'll stop there. I could talk about bed numbers for a very long time, but I'll stop there.
Thank you, Helen. We do have a few more questions coming in that we need to get to. So I have a question about parking at St Albans, and perhaps, I don't know, Esther or Helen or Freddie, I will look to see who puts their hand up. My understanding is that we aren't necessarily going to be bringing more patients to St Albans or necessarily more patients to Hemel Hempstead. So I'm not sure that we need more parking at St Albans, because some services will be moving from St Albans, and some services will be on the one-stop model. So there will be fewer journeys, but maybe longer appointments, if that makes sense. I don't know if anyone else on the panel wants to add to that at all.
I will just come in. I think that that's absolutely the case overall. I think that there is going to be a bit of a challenge with car parking at St Albans, and we will be looking at that quite carefully. One of the options or things that we'll be looking at is what provision can we make for our staff so that there's enough capacity for patients. Obviously, you can't run services without staff, so they do need to be able to get to the hospitals and park. But we're very aware that it can be difficult. At Hemel, we've got more flexibility. At Watford, we're confident that our new car park will provide the capacity that we need. I think St Albans, probably a bit more work to just make sure that we've got enough car parking there.
Thank you. And Esther, I wondered if I could come to you with a question about the MRI equipment at Hemel Hempstead. So it's now quite old. Could you tell us anything about upgrades for equipment at Hemel Hempstead, please?
Sure. So we know that we will need to replace the existing MRI at Hemel. As you said, there's a finite lifespan for MRIs, and we know that the Hemel one does need replacing on that basis, but we're also looking at where it would be best on the site, so that we make those pathways for patients, and when they come in, as sensible as possible, and the MRI is very readily accessible. So at the moment we're looking at what the options would be and where it would be best located, so that we can make sure that it's got the right supporting infrastructure and it's in the right place to make logical patient journeys.
Thank you very much. We've just got 2 more questions that I'd love to fit in, please. So one is a question that I think Brian would like to ask. So if you're there, Brian, and you can get yourself off mute, please go ahead and ask your question. While we're waiting for Brian, I'll just address another question about parking. Is parking going to be free? And I believe that's a national decision. I don't know if you have any more information, Helen, on parking. At the moment, parking charges have been suspended, but that's not really a decision in our control. Did you want to add anything, Helen?
No, I think that's absolutely right, Louise. I mean, obviously it does cost to provide car parking, and at the moment we're expected to cover those costs through charges. Suspended during COVID, a lot of national debate, a lot of political discussion. We wait to see, but we will obviously follow the national policy on car parking charges.
Thank you. And a question about intermediate beds, or beds for those people who are not quite well enough to be in their own homes, but not quite poorly enough to need care on a consultant-led acute site. So I don't know, Helen, if you can have a very quick stab at that, and then we must get to Brian before we finish. So.
Yeah, so just quickly on that, the Trust does not intend to provide any care, bed-based care where patients don't need consultant-led care, because we don't think we're the best organisation to do that. Community London CLCH, actually I can't quite remember what it stands for, are the key community provider. They're working with the CCG and social services, and through later in this year, they will be engaging with local people to talk about what their plans are. But primarily, the aim is to get people back home or into their long-term care setting as quickly as possible. So unless there's an active need for rehabilitation, we will be working to make it a much more home-based provision.
Thank you, Helen. So Brian, hopefully we can hear you now.
I hope so. You hear
yes,
that?
Great, lovely, yeah.
This is my first time up on these, but what is the overall timescale for this? And is the need to catch up on outstanding treatments going to delay that at all?
Shall I come in on that one?
Please, Helen.
So no, to the second question, no, the need to catch up on existing treatments won't delay the timeline for the redevelopment. We've got a whole team and a separate set of resources to make sure we keep moving forward with the redevelopment. Our clinicians are working extremely hard, both to care for patients with COVID, to think about how we do catch up on lost activity, but also to support us to make the right plans for the future. But they're really, really keen to do so. So we don't believe that should slow us down. The overall timeline for the redevelopment, we want to do this as quickly as we possibly can, because absolutely our current buildings and facilities get in the way of providing the really best care that we would like to do. There is a lot to work through, and a lot of work that needs to be done to get us to the point where we can open new hospital facilities. We're aiming still for 2025-26. There are a number of things that need to be true in order for that to happen, including getting our business case approved and confirmed funding, identifying a contractor to build the hospital with us. There's a lot that needs to happen, but we're really determined to keep pushing this forward and get those new hospital facilities open as soon as we can.
Thank you. And sorry, Brian, did you want to just come back quickly?
No, just thank you.
Lovely. So thank you. We've had some great questions today, and we've got through, I think, pretty much all of them, and we will take a note of all of those that we have had. So it's really, really useful. Thank you so much for your time this morning. It's so helpful for us to hear from you, and I hope you can spread the word a little bit and maybe get us some invites to some other meetings. We don't get out much, so we're very happy to come out to community groups and talk to you about our proposals. We'd love you to do the survey if you haven't done it already, and please join us when we have some more in-depth sessions with some of our fabulous clinical and non-clinical staff. So we hope we will see you again soon. Thank you particularly for new people who've joined us today for the first time. You're all very welcome, and look after yourselves. Thank you.